everybody. Thanks for joining the meeting today. I am a manager for Lake Health in their physical therapy areas. So I manage an office in Mentor at the Mentor Heiser Racket Club, formerly AGM Physical Therapy. We'd been in private practice for a bunch of years, but we merged our services with Lake Health last summer. And in the interim time, I'm also managing now the Perico Health Campus, which is at 306 and 90. And also the physical therapy department out of the Madison Medical Campus out in Madison on Route 20. So I'm going to speak to you guys about hip pain and knee pain, which are really statistically some of the two highest incidents of pain in the body, along with shoulder and back pain is probably the other two. But there are a lot of documented cases of knee pain and hip pain. And so if you Google anything about that, you're going to find all kinds of information. I know, one of the folks listening today, Deborah, she showed us that she is investigating something related to an injury. So hopefully we can give some information to her about that. But, the whole body as it is certainly interrelated, across the body. We always hear it's all connected, and it really is all connected. Certainly the hip and knee joints being right on top of one another do influence each other significantly. Speaking with the hip to start out, it's a ball and socket joint, and it's a pretty stable joint. It's one of two ball and sockets. The other one is in the shoulder. The hip is more stable than the shoulder because it has a deeper socket and the ball fits in it more snugly. You have a piece of cartilage that wraps around the top of the hip socket called the labrum, which adds more surface area to contact into the joint and also helps to cushion the joint a little bit from shock. But there are various causes of pain throughout the hip, everything from osteoarthritis and rheumatoid arthritis to strains to bursitis, fractures, labral tears, and even what we see a lot in physical therapy is people that think they have hip pain and they may actually have pain coming from their back through a little nerve irritation that is projecting pain toward the hip area. But the knee being right underneath it, same types of things can be affected. The joint can undergo osteoarthritis or degenerative joint disease, sprains and strains. It's a little bit more subject to soft tissue injuries just because of the design of the knee. It's only a hinge joint, so it doesn't have the same depth of movement as a hip joint does. So we do end up seeing more ligamentous injuries because it has a little bit less stability because of that. If you think about sports, if any of you watch sports, we have ACL tears, MCL tears, all these ligamentous tears in the knee, which end up being the result of too much load over the course of the ligament and either stretches or tears because of that high force. You also have another joint at the knee. We think of the kneecap. It's really its own little joint called the patellofemoral joint. And that's held together by two strong tendons and then some soft tissue on the side. And that can give its own pain that is independent of the actual knee joint proper itself that's formed by the upper and lower leg bones. I think if we talk specifically about arthritis, that's one of the largest producers of pain in these joints. And when you look at the most common replacement of joints that people get, it really is the hip and knee. We do see some total ankle replacements nowadays, total shoulder replacements, but far and away the hip and knee are the two most commonly replaced joints. The technology for those replacements has come a long way. I've been a physical therapist for over 20 years now, and the type of components they put into the body with the prosthetic componentry in there has come a long way. It's gotten smaller. The incisions they make to get into the joints are much smaller. So the collateral damage that's done during these surgical procedures is less on the body, and there's much less stress, which makes my job as a physical therapist a little bit easier than it used to be. Our goals for functional outcomes and range of motion and movement patterns after these surgeries are a lot more aggressive than they used to be because the expectations are more. We have people getting these types of surgeries at much younger ages than it used to be. What used to be, kind of arthritic changes being kind of a death sentence for movement and mobility really are no longer that way. By no means is the recovery process an easy situation for people coming off of a major surgery like a joint replacement, but majority of the outcomes you look at 1 year or 2 years after surgery, and people are really happy with the choice they made. From a physical therapy standpoint, I evaluate these injuries with, the eyes of really looking at the anatomy of what's going on. The arthritic changes that we see, we know that there's not much you and I can do together to change arthritis that's happened, but we can do a lot to influence the stress that goes through the joint. Most often with any kind of arthritic change, we see tightness in the tissue that's there. So we lose joint mobility, we lose function because of the pain. And inevitably we change our movement characteristics to, sort of adjust to the pain that's going on. So a lot of overcoming something, if you're going with a non-surgical approach, is to restore mobility to the joint, restore proper strength, really work on things like balance and timing and the control of your body in certain movement patterns. And, at times understanding what your body can and can't do, and looking at, is there an activity modification that has to occur, or, are you willing to pay the price with the discomfort that you have depending on what you do? Specifically at the hip, we don't see as many strains. We do see them in athletes. You're looking at things like your hip flexors, which are on the front side of the joint, a gluteal muscle, which is your rear end muscle. Those can be strained. They're very large, powerful muscles, but they are also very protective around the hip as well. More commonly, I treat, the adult population probably more so than the teenage population in terms of the number of injuries that we see. I would say, it's arthritis, bursitis, and labral tears. We're seeing a lot more labrum tears that are diagnosed because of the technology of diagnostics. MRIs reveal a lot more soft tissue damage. And then the surgical approaches to fixing the hip from, a connective tissue standpoint has gotten a lot better as well. Statistically, you're looking at arthritis throughout the body that, costs the medical industry over $300 billion a year. In terms of chronic pain, going to the knee specifically, it's the second most commonly referred to joint for chronic pain. And 1/3 of all Americans throughout their life will report some type of knee pain. So that's a pretty staggering statistic when you think about the number of people that live with pain without having it treated. But, again, going back to what I treat every day, it's a really common injury. I would say, that 1/3 of all Americans reporting knee pain. Some days it's a quarter to the type of, quarter to 1/3 of the injuries we see in the clinic that day are knee injuries. Again, incidence wise, going to the knee, it's a little more subject to the stresses that come from above and below it. It's caught in the middle as a hinge joint. The ankle is a very versatile joint. It has multiple planes of movement, as does the hip. And if you don't have good strength at your hip, or maybe you're weak in your ankles, some of that load that comes from the bottom up or the top down kind of wiggles through the knee and can predispose the knee to adverse angles of pressure and load. And then you compound that with maybe someone that has arthritis where half the knee joint isn't, as accepting of weight bearing because of wear and tear. And now you get the incidence of pain. You can change the way you move, and the way you move might influence other connective tissue that comes down between the hip and the knee, and you can get tightness in other tissue, something called your IT band. The other ligaments, the things that hold the kneecap in place, can become unsteady or overloaded, and the kneecap can start to move odd, and then cause pain in that patellofemoral joint. But most of what we see when it comes to connective tissue outside of the knee arthritis injuries are relatively rehabable without surgical intervention. Some do require it. Most injuries after surgical intervention do require some type of rehab following that, though, too. And I would say, conservatively, if you have non-operative approaches, we're looking at a couple months of rehab probably doing the trick. If you're looking at something post-operative, you're looking at more like 2 to 4 to 5 months of potential ongoing rehab to do a good job of getting that better. Overall treatments for pain, I think a lot of people undergo, non-steroidal anti-inflammatories as one of the options, where you just take an over-the-counter medicine or potentially a prescribed medicine from your doctor to see if it will reduce inflammation. Injections are also tried. If you guys have had arthritis and have injections, you probably had some type of steroidal injection like cortisone or something like that into the joint. And those work, but those don't work sometimes. And sometimes it just depends on what's inflamed and is it really going to respond to the steroid injection or is it not? Sometimes it's the technique of the practitioner putting it in. Do they have the skills to put it in the right spot at the right depth and treat the right tissue? And everybody's got different skills that way. There are newer strategies out there called PRP, excuse me, which is platelet-rich plasma, as well as prolotherapy, which there are some local doctors around here in Lake Health and other systems doing that type of therapy, where essentially it's an injection of a substance that promotes growth of normal cells, tissues, and organs. And you can do those into tendons, into the joint, into muscles. And it's really, if you would look up the phrase regenerative medicine, that's really what it's describing as a non-surgical approach to trying to grow new tissue in an area where, tissue has either been degraded or injured itself specifically. Leaving another treatment option, obviously physical therapy, I've discussed that a little bit already, is an option for that. And within the realm of physical therapy, it's everything from stretching and strengthening to manual therapies where we handle your tissues in our hands, whether it's your joint or soft tissues that surround a joint, trying to create soft tissue mobility patterns to increase your movement and reduce your pain. We do dry needling therapy, which is the use of acupuncture needles in a way similar to acupuncture, but not necessarily specifically that, but utilize acupuncture needles to go into places surrounding joints and at the level of joints to increase the blood flow and viability of the tissues, stretchability, reduce trigger points, which are often tied into people's pain patterns. And it's used as an adjunct to the typical physical therapy things we do, like I said, between stretching and strengthening and soft tissue work that we do. On occasion, if you are working with someone like a therapist and we see that hip pain or knee pain is not responding whatsoever to conventional treatment methods, we might do some testing of your lumbar spine and find that we think maybe there's a pinched nerve coming from a herniated disc or a bulging disc. And that might be something to refer you back to your doctor to have some other diagnostic workup. But that would be the other thing under treatment is, what kind of diagnostic workup do you have? Is it just x-rays? Did you have an MRI? Many insurances nowadays are requiring some type of physical therapy prior to allowing an MRI or an injection series to happen, as opposed to just going straight to an MRI based off of the doctor's opinion and referral that way. Those are sort of just some highlights of what type of injuries you can have around the hip and knee. I would probably prefer to open this up to question and answer. I think people that want to know information about these joints may either have the pain or want to know more information about it. And I think, questions from the group could probably answer other people's questions that are listening, or at least give them the insight that they need to make a better decision if they have some questions. So if you want to open it up, Amy, I'm open to questions now.
Okay, sure. Anybody have any questions? You can type them in the chat. Can you guys hear me? Type them in the chat or ask Greg in person here.
Yeah, you could undo your mute on your microphone. Just ask if you want.
Well, I have had 2 knees done. So I know I have osteoarthritis, and it was very successful. They were done at the same time in 2012.
Mm-hmm.
My hip is in problems now, and it's a result of immediate and severe lack of activity. Prior to COVID, I had a really busy schedule, and it kind of just stopped, and then I fell. The fall didn't have anything to do with it. I've had an x-ray, and what they're saying is my space around the pelvis and where the socket is 70% compromised with arthritis. Knowing that, I've accelerated my workouts because I'm actually thinking, well, I don't have a broken bone. I can just see how far I can take this, because I went pretty far with my knees.
Yeah.
Question to you is, and I did do a series of physical therapy at Peter B. Lewis in Beechwood all last summer after the fall. It did improve, but I got stuck. We decided I was basically going to be someone that can't put my left leg, my right leg over my knee anymore to put my socks on. And I don't want to accept that. So that's why I'm at the pool.
Mhm.
I tread water for 45 minutes, doing bicycles and different clam shells and whatever I can do with water. My question is there a likelihood that arthritis can move or be, can the space reopen based on exercise and strengthening and all that? Because I feel like I've been compromised by lack of activity.
Yeah, it's a good question. Arthritis is weird sometimes. You can have a lot of arthritis by X-ray, and sometimes not have a whole lot of pain. And then you have something that happened to you, that you fall, you inflame the joint because you jam it or twist it in a way that isn't normal. And now that inflammatory pattern is persistent and it's hard to get it to go away. And then you have the workup done, and sure enough, boy, this hip isn't in very good shape, is what you're told, but maybe prior to the fall, didn't seem to you maybe like it was in that bad a shape, so it's a battle of living your life day to day and figuring out what hurts it the most. You don't want to sabotage yourself where you just do it in spite of yourself, trying to do things that cause pain, but you want to live your life and, like you said, not give in to the fact that I'm not going to be able to, I don't want to accept not crossing my leg over to put my socks on. I admire that spirit. Like I said earlier in the talk, I can't, if there's 70% change, I don't know that I can change what's already showing wear and tear. But with respect to the amount of space that is afforded in the joint, so if you have this ball and socket joint, instead of looking at like my fingers that are ridged, normally that would be a smooth round end of the cue ball kind of thing, and it sits in the socket. So if it's clunking or bumping around like a ratchet, that's kind of what hurts, because that surface of cartilage isn't smooth anymore and protective. But there's also an envelope of soft tissue that surrounds the joint that can get constricted and tight. So as you try to move your hip joint, it gets impinged or blocked by the tightness that surrounds it. In my opinion, that's sort of where I would think you have some possibility to help reduce the inflammation or reduce the limitation in your joint, is if you can actually get into some positions where you're getting some stretching of the joint tissue that surrounds, like, again, it's capsular inert ligament is tissue. It's not necessarily the joint itself. We're not stretching the joint, we're stretching the stuff that surrounds it. That would be where I think, your best possibility of reducing your pain and maybe increasing the function that you've lost back to something better than what it is right now would occur. Now, how do you do that? You almost have to be able to take the tissue to a point where you're going beyond its current restriction. And I think going in the pool and other exercises are great because they're unloaded and they're keeping your mobility that you have, but you're hard pressed to really get that to extend beyond where it's tight, because either you meet the restriction and you can't push through it, or it hurts. And both of those are difficult to get past. So, not to, this isn't a commercial for physical therapy, but outside of somebody to do like joint mobility work on you, like an osteopathic doctor or a physical therapist or someone with some hands-on skills, it's hard to do it on your own. But that's how I tend to approach people with really restricted hip motion, is to really start applying, and they're really pain-free for the most part, joint mobility exercises to it, so that if we can get it opened up, then we can release you back to your own accord, and you can just keep doing exercises that keep you feeling better. But I mean, that's probably your biggest chance, is to increase the mobility of the tissue, the connective tissue that surround that tightness, and try to free up some of the joint movement.
The reason I feel like that's a possibility, and I'm glad to hear you say it, is many times, like right now, and I know I just came from the pool, I am in no pain whatsoever. So I know I can be situated and exercised enough,
Mhm.
but then I get that whole frozen thing.
Yeah, it gets
So
set.
activity that needs to continue so that you can keep the lubrication going, the synovial fluid, you learn all these terms and you're like, okay, what am I doing? So that was very helpful to hear that feedback, because I don't want another hip, I don't want another replacement, because I feel like one precipitates the other. I don't want two. One knee, usually you wind up with the other one. That happened because I was literally on my knees. I couldn't walk. So I had to get it done. But after that very successful outcome of the knee surgery, I was able to dance, be an usher, work in a preschool, walk, really active stuff, ride a bike.
Mhm.
So thank you.
Yeah, you're welcome. And I'll just reiterate something I mentioned earlier in the answer to your question is, if your hips were a little arthritic anyway, but weren't really causing you any pain, and then the fall happened and most of the pain happened after the fall, unless you structurally did something new during the fall where you jammed something and it made it worse traumatically, then my guess would be a lot of your pain that you've been dealing with since then is just that inflammatory stuff. So you haven't gotten out of the inflammatory cycle from that. Now, long-term inflammation has been shown in studies to kind of eat away at some of the the cartilage surfaces of the knee. So I mean, it behooves us to get rid of that inflammatory cycle. Everything from your basic, can you ice it to give yourself pain relief and get some swelling down? I mean, it's hard to tell that you can feel hip joint swelling. They call that an effusion in the joint, but those other types of injections that we were talking about, I saw a question someone was about the regenerative medicine, but like, possibly looking at PRP or prolotherapy, something, because it's designed to, inject something that promotes growth of normal cells. And if you have a lack of that going, it wouldn't hurt to investigate that option prior to really making a decision about some other surgical intervention if that's not what you want to do. I will say this, a lot of those regenerative medicine injections, it's spotty whether or not insurance covers them, and they can be fairly costly out of pocket, decisions.
Right.
But that would be something you really want to collect some information from the doctor who might be, doing those for you, and really ask about their success rate, how often they do this, how many patients they've seen, get all those statistics on it, because it's a big expense for something that, you hope it works. You want something a little more than I hope this works, when you're making a big decision like that. So.
Thank you.
There's a couple questions. Did you see, Greg?
Yeah, I just
what can I do for sciatic pain?
Yeah.
That one.
Well, sciatic pain is sort of a, can be sort of a catch-all description of pain that is running down the leg that we think is coming from a nerve area. That nerve area typically, it can be anywhere from the low back to the nerves that course through the rear end. There is something called a sciatic nerve. It's a 2-nerve bundle that runs from really the top of your rear end all the way down to the back of your knee before it splits into 2 separate nerves. I think, looking at sciatic pain, we're looking at, what's the trigger? There could be a lot of things. A lot of people can't sit for very long when they have sciatica. Other people can't, handle loaded situations where they bend forward and try to pick something up. Some people have relief with certain positions, and that's how we look at things, from a PT standpoint is, have you found anything that relieves the pain? Have you found anything that makes it feel worse? So naturally avoid the things that exacerbate, try to lean toward the things that, relieve it. But generally, I think, sciatic pain is more of a central nerve process that comes from the low back. So it really is looking at, is there something more specific to a herniated disc, a bulging disc, some type of stenosis, which is a narrowing of the spinal canal that puts pressure on nerves. I think we need to look at, what is the precipitating mechanism that's causing the, the pressure on the nerve that is going that direction. It can also be poor posture. You'd be shocked at how many people I give for home exercises, just postural correction techniques, starting from the low back where, they're getting up taller, bringing their upper back up, and just starting to minimize the stress that goes through certain joint tissue and nerve tissue at the same time. To answer the question, what can we do for sciatic pain? There, I could talk to you about an hour about different things we could do. Everything from dry needling that I mentioned before. So if you've got a nerve area, that's coursing through the piriformis muscle in your rear end area, and that muscle is in a spasm and it's pressing down on that, trying to do trigger point release, with dry needling or hands-on techniques, stretching techniques. You can add more to that chat question if you want to, but I don't have my question back to that person that asked it would be, what have they done so far for that? Has there been any other prior treatment for it? I'm going to go down to the next question. This is how much have you seen much success with regenerative medicine for the knee? This person has an enlarged knee on the right side, stress due to putting off of a hip replacement on the left side for too long. As far as success goes, I don't do those specific injections. I work with some doctors in the system that do them. They are huge believers in it. They're trying to get more push through the health system to, I think, market the use of them. Again, if you don't know anything about the way they do that, they basically they withdraw blood from your body and they spin it out. Basically, they try to separate the platelets and plasma, which is just the fluid part of the blood, from things like the red blood cells, the white blood cells, and other blood components. And then they re-inject the plasma back into your body. And when that breaks down, it releases stem cells and helps things grow. So within the knee, you have meniscus tissue, you have joint fluid, you have the articular cartilage surfaces, which is the lining of the cartilage that protects the knee. The regenerative medicine isn't necessarily going to regrow new cartilage tissue if there's breakdown. In your specific instance, if you are overloading the right side of your body to compensate for the left, it's causing some strain to that knee. So I guess we'd have to look at what's going on in that knee. Is there some wear and tear in that knee that's getting irritated by, whereas there's an outright injury in the right knee, as well as having a bad left hip. And if so, do we treat the hip more aggressively to take the load off the right leg? But as far as the regenerative medicine, if you research that at all, it's still going to tell you there's a lot more studying that needs to be done as far as using PRP or prolotherapy injections. And in my honest experience with it, it's kind of hit and miss, to be honest with you. I've seen it used around the elbow for tennis elbows, some around the hip, some around the knee. That's why I was saying to Deborah, if she investigates the use of those injections, I think I'd want to know from the doctor what their personal success rate is. How many knees have they injected? What's their technique that they use when they do it? What do they expect in terms of the time frame for improvement? Because sometimes you have to wait a little while for those stem cells to start working. It's not an overnight success story. I think a lot of people, even with cortisone injections, want there to be overnight success. And many times they're disappointed because they get it, they don't feel immediate pain relief right away. So it's an emerging aspect of medicine as far as the rehabilitation pathways. But I would say, I've seen as much of those injections not work as many as they've worked. It's about 50-50. So hopefully that answers your question. To going back to the sciatic question, the description was it was in the muscly part of the rear end. The person tried massage and muscle relaxers. Sleep improves it, but seems as though sitting with his feet up on the ottoman triggers it, as well as walking. So, when it's in that part of your body, again, I would look more toward the low back itself to see if there's something central that triggers it. Movements that create backward bending versus forward bending versus side bending to the side where you have your pain, twisting to the side where you have your pain, are those movement patterns that, trigger the pain to come on or potentially relieve it. As it courses through your rear end, there, again, the sciatic nerve starts in that area and it's covered up by a whole bunch of muscles. So there's a bunch of rotator muscles that kind of work in a fan-shaped pattern when they're asked to contract or work, they can put pressure down on the nerve. So if you've got tightness on those muscles, stretching those muscles out is something that probably needs to be done, or potentially strengthening those muscles too. They oftentimes get weak when you have pain in that area. But I would probably want to take a look and see, what type of low back assessment triggers that sciatic pain, if anything. And if it doesn't, then we would look more peripheral down into where like you said, the meaty part of your pain is occurring. Anybody that wants to contact me, I can give you an email address before I sign off today, and you can contact me through email, and I can maybe call you directly or something to give you more specific information if that's going to help some people. Okay. One other one is they tweaked their knee a week ago, no specific injury, the knee will buckle. Pain is occasional on the ligament, inner leg area, but near the kneecap. Is it patellofemoral? What can you do to treat yourself? Specific to a knee injury like this, when you tweak it, tweaking can happen in a lot of ways. You could slip and have a twist. You could walk up the stairs and have it hurt. Again, depends on the mechanism of injury, but when you have an injury like this, it's more acute. If you don't have a history of knee pain in the past, this would just be some general guidelines for anybody who, thinks they may have tweaked something. The basic things, how is your pain? What makes it hurt? Is it swollen? Is it not swollen? If it's swollen, we want to try to do things to get the pain and swelling out of there. So the old adage of rest, ice, compress, elevate, that's still pertinent. Most of the time, if you have a twisting motion to the knee when you're in standing, and I'll just stand up and show you. So if I'm standing on my feet and I just twist my body like this, where I have like a rotating motion through my knee, if that causes pain, there's a one-legged test for that indicates maybe that a meniscus has some damage to it. Many knee injuries like this will tend to heal in about a 2-month time period if you're just looking for ballpark estimates. But there's some basic range of motion exercises you can try, just literally bending and straightening the knee, tightening your thigh muscle. So if this is my leg and this is my thigh muscles, and I tighten it and I lift my leg up in the air straight up and down, it's called a straight leg raise. Making sure that that's your quadriceps muscle, making sure your quadricep muscle is doing an adequate job of, controlling the forces through the knee. Oftentimes, if you're looking to treat yourself, Chris, you want to probably, keep things out of weight bearing for the time being. As far as squatting, stooping, lunging type movements, you have to be careful on stair climbing. You'd probably want to go, up with your strong leg first, down with your injured leg first. When you're looking at it's up with the good, down with the bad on the stairs, just to make sure you're not overloading the knee. Taking it conservatively usually does help quite a bit. If you can walk with pain and it makes you limp, I would try to suggest don't walk with a limp even if it hurts. So my description of that is, pain can just be a thing. If you're not making yourself any worse just by walking, then try to walk more normal, because if you limp, you start using other muscles that make other things hurt. But I would focus on just restoring your normal range of motion, bending the knee all the way, straightening the knee all the way, and doing a series of leg raises throughout the course of every day, and icing it to help rid of pain and swelling as your, kind of 3 basic things to do as far as getting started. And then, working things back up onto your feet after a couple of weeks if it starts to feel like it's better. There's another one that says her legs are stiff. She's had knees replaced. What exercise can you do, or what can be done for the pain in my legs? If you can give me more detail as far as my legs are stiff, that could be anywhere between your hips and your ankles. And it could be the joints themselves that could be stiff. How long ago did you have the replacement? If anyone wants to talk to me, they can take the microphone off. It might be easier to have a discussion that way.
I had my knees replaced in 2013. I had both of them done. They're metal knees with plastic spacers. Okay. And all of a sudden, about a year ago, my legs became very, very stiff. It's like I'm walking on boards. And I've gone to the doctor to put my knees in. I've gone to my arthritis doctor. I have rheumatoid arthritis, very bad. And nobody can seem to help me. Now, the last week I went to a neurologist, and I have an appointment for an MRI this week.
Are they going to do an MRI of your legs or your back, or
my back, he said.
your back?
Yeah, they seem to think it's something in the I have arthritis very bad in my neck and in my back.
It could be that they're looking for, I said the word stenosis earlier. I don't know if you were on then, but
Yes, I did.
stenosis is it's a degenerative condition in the spine where you get, basically degradation of the disc tissue that separates all your vertebrae. So your vertebrae start getting compressed, and the nerve areas that come off of each vertebrae, as they get compressed, they get squashed. So it's just, they get a lot of pressure. And it's not uncommon for people that have severe, spinal stenosis to have a feeling of stiffness in their legs because all the nerves are just getting jammed up from load. If that is the situation, then oftentimes, we'll try to recommend exercises that, try to get them to be more neutral with like a posture position, or one that biases them toward it's called a flexion bias, but bending exercises. So things like knee to chest, if you're lying on your back, bringing knees up this way. If your knees are stiff from your replacements, we can grab behind the leg and pull that way. Or even if you're sitting, doing forward bend activities where you're bringing your chest and torso down towards your thighs. Do you find that you can't walk very long before your legs start to really get labored?
Oh, I can hardly walk at all.
That's from the start of the day?
Yes,
And this is about a year ago, you said this started happening?
right.
And as far as the orthopedic is concerned, the knee replacements look fine, probably, right?
Yeah, I went to Dr. Peterson and he
Mhm.
took new x-rays and they're fine.
Mhm.
There's nothing wrong with my knees. I went to Dr. Eubanks, and he's the one that took the MRI, the x-rays of the spine.
Mhm.
And he's the one that said that my back is very bad and they could operate, but he said it's very dangerous. I'm 80 years old.
Mhm.
So then
Yeah.
he sent me to the neurologist who I saw last week, and I have an appointment for an MRI this week.
Okay. Have you done, do you find that any positions make you feel better? Just out of
Yeah, when I'm
self-preservation?
Sitting.
when I'm
Sitting?
sitting.
So
My leg doesn't hurt, it's just stiff.
yeah, they feel heavy, like there's pressure in them.
Oh, God, yes.
Yeah. Just based on this brief discussion, I would say they're probably on the right track looking at your spine. If our x-ray showed
Uh-huh.
severe arthritis, then more than likely you do have, some pressure on multiple nerve areas that are exiting the low back area. And if those nerves, think about that, they're just getting choked or starved of their normal supply of nutrients because there's just pressure on them. So, they supply the lower extremities with all of the motor function that they would normally have. And if the water supply at the top is being pinched to a drip, instead of a gushing amount of water, then everything downwind of that's going to sort of, lose its ability to do what it wants to do. If you don't have any, you haven't had hip replacements or anything like that, right?
No.
Okay.
No.
I guess I would suggest trying the things that I mentioned. It doesn't sound like it's very complicated or why, that it would help, but
Uh-huh.
maybe if you every hour or so, just from a seated position, maybe sit at the edge of the chair and see if you can bend forward as if you were going to try and touch the floor. Whether you make it to the floor or not with your hands doesn't matter. You're just going to go in that direction. Almost like, are you looking at me right now?
Yes, I am.
Okay, so like if I'm sitting on this stool and I put my hands together, I'm just like gonna dive my hands toward the floor, like I'm just trying to touch the ground
Uh-huh.
and then back up. Again, if you only go down part way, that's fine, but you might find that little by little, if you repeated them, 10 or 15 slow times, you get a little bit further toward the floor every time you go. And if you tried those once an hour, what we're trying to do is if this is the joint space and it's shrunk down now, everything that happens when you get upright tends to compress like this even more. So
Okay.
Standing is tougher than walking because when you walk, your legs exchange movements. So your pelvis moves this way with one step and backward with the other one. And when you switch the other direction, you're getting at least some movement, but standing still really builds up a lot of load. Being upright, sitting, can be more load than lying down, but certain ways you lie down, I wouldn't lie on your stomach. I would say, lying on your sides may give you more relief than lying on your back. But if you tried when you're laying down at night or before you get up in the morning, maybe prior to movement, just so you're trying to do like a testing pattern before you move, or like if you have to get up and go to the bathroom or something, try those forward bends. And then when you get up immediately, maybe you'll find that it's easier for you to walk at least a short distance in the house. It's better than nothing when, we first start trying things out. If you're lying down in your bed in the morning, maybe try when you're lying down, try some knee pulls where you're just trying to pull your knee up towards your chest. And see if that makes your first walk into the day any easier. So you're essentially building in some decompression to the nerve areas in your back prior to getting up. Because when you first get up from sitting, it's a pretty drastic shift. You're going from here to upright, and that upright load just puts a whole bunch of pressure down on your spine.
Okay,
So maybe try to keep your spine a little less loaded prior to movement and see if that helps you.
okay. I have a person here and she has a question.
2 for 1. Okay.
Yes, I was admitted to the hospital last week because I had this awful pain in the hospital called it my right flank. After 3 days, they came up with the diagnosis that I had a pinched nerve in my right flank.
Mhm.
So I'm having physical therapy right now. And if that doesn't relieve it, then they suggested I see a pain management doctor.
Okay.
Does that sound?
How does that sound?
Yeah.
It sounds reasonable. I would, I can't speak for what every physical therapist is going to do to help treat that, but there should be some movement-based activities or some hands-on things they could do with you in physical therapy that would help relieve your pain. Pain management, we work all the time with those doctors. So, again, as their name suggests, they're really dialed in on, trying to locate the epicenter of where that pinched nerve might be. And sometimes it's, referrals to therapy and they don't do any medication. Sometimes they try something medication wise to calm your nerves down. Sometimes they try injections. Those are things to discuss with that doctor if the therapy doesn't work for you. But I would feel confident in saying that, you have a very good chance that the physical therapy should help you have, your pain taken away.
Well, when I'm sitting, there's no pain at all. And when I first get up, I'm good for like 10 minutes and then the pain starts and I have to sit back down.
Okay. I mean,
Right.
it's maybe the same description as what I was saying to Eileen is, you get up and there's just so much load that just keeps building and building and building, and your body can only take so much because it just keeps getting tighter as you stand. And sometimes there might be some muscle, issues with that where we got to work on stronger. I mentioned posture earlier in the talk, really maybe dialing in on your posture to see where your limitations are and if that's affecting how your pain, is occurring. So I would think they're going to try some stretching and strengthening as well as some, again, maybe some hands-on things with you to help increase your joint mobility.
Some of my friends have suggested that cannabis would be a big help.
I can't really speak to that. I mean, we do have people, nowadays that are doing the different ointments and things like that do seem to help relieve some of their pain. But I mean, that's kind of an emerging market of pain relieving options, I think, that are out there for people to try. It just, I don't have a real strong opinion on them yet because I don't think we're really seeing enough of it to know how much that affects them or not.
Okay, thank you.
You're welcome. I'm going to address that question from Deborah. Do I give credibility to orthopedic shoes to give more stability over bare feet? I don't know that I would agree that the phrase orthopedic shoes is what I'm referring to here, but I think people, when we think of when we're babies on up, we're able to walk barefoot from a younger age up to a certain point. And a lot of people don't feel comfortable wearing, no shoes on their feet, yet they don't want to wear shoes in their house. So different injuries happen to different people's feet. You can have a normal foot type when you're younger, and then all of a sudden, have something happen where you end up with a collapsed arch where there's no structural support to your foot, and it can cause pain on the ankle joints and some of the tendinous tissue that affect the control of the foot and ankle. And those are people who oftentimes need something on their feet that gives them some correction to their arch or support to their heel, so their heel doesn't deviate inward outward, that allows their arch to stay high, or the heel to, or the foot to collapse in the arch. So I think the real answer to my question is it just depends on the individual. I'll take me, for example. I've got a pretty neutral foot type. So I can handle being barefoot and it doesn't seem to bother my feet, but I know other people who absolutely have to have something on their foot. So nowadays they have, corrective sandals and stuff like that that people wear on the house. I've even seen corrective slippers, something that builds up some neutral base to the bottom of their foot, so their foot is, not collapsing one way or another. So I don't know that I would recommend people go barefoot. I really just think it depends on the person and what kind of injuries have happened to them over their course of their life, or they've had a fractured ankle, or they have flat feet or high arches. Some people, plantar fasciitis, the heel pain that people get a lot of times. Many people need some type of foot correction underneath their foot. So does anybody else have a question?
Greg, there's one in the chat about massage guns. What is your opinion of the massage guns that are popular now?
I love them. Actually, we've got 2 of them here in our office, and we use them as an adjunct for our other types of manual techniques that we use. I think we have really good results with them. It can deliver a type of impulse to the muscle that we can't deliver with our hands, based on the speed of the impulse that it's giving. And when people have trigger points, and a trigger point is a muscle spasm, it's a hyperexcited spot in a muscle that usually, the knot, whatever you want to think about, that comes up here, your low back or other parts of your body. And they're very effective on those to relieve the pain that's associated with the trigger point. It helps to reduce the actual trigger point. And, we use dry needling, I mentioned a couple of times, with these acupuncture needles, and we're trying to find a trigger point where we actually make the muscle go into what's called a local twitch response. So you insert a needle and you look for the muscle to kind of just flicker, which is an involuntary contraction, but basically it's a breaking up of the trigger point. And we get a very similar effect many times with the massage gun. You get blood flow to the muscle area because of the massaging action of that. But I think you get a greater effect on not just the feel-good massage, but again, the breakdown of trigger points when people have some real significant known active points of pain. They can be really effective. Now you have to be careful with how you use it. I mean, there are different depths of pressure that you use, the different speeds. So typically I tend to use ours only on speed level number 1 here in the clinic. And at the most I go from a real mild superficial amount of pressure to something that's only maybe in the medium range. But I think they have a lot of use and benefit, not just in a therapeutic world that I live in, but even in a kind of a feel-good market at home. But if you're someone who's suffering from chronic pain, more often than not, you're going to deviate how you move your body. And when you deviate how you move your body, you're going to end up with stiffness in muscles that, leads to other pains just secondarily. And I think that's where the massage guns can really help out, reducing some of that pain, especially in muscle groups. No worry about blood clots when using such pointed pinch to the muscle. I haven't seen anything that indicates any research that ties blood clots to using the massage gun. Anybody else? I know ice or cold is recommended for inflammation, but why does heat feel better and heat bad for you? Heat's not bad for you. It's just it's more soothing than cold is. For many, I've been a PT for 21 years, and I probably recommend ice over heat on about a 10-to-1 ratio. I've just, some of that's anecdotal. I've been an athlete my whole life, and anytime I get pain or some kind of injury, I feel like ice does a better job of relieving the pain, number one. And I think, when you look at overall blood flow in the body. In an area that has swelling, cold tends to vasoconstrict, so it doesn't allow as much fluid to pump into an area. Yet your body is going to try to heat itself back up after the cold is on there. So it's going to bring blood flow to it no matter what when the ice is off of there. So you kind of get this contrast of, restricted flow to an increase in flow. And sometimes that increase in blood flow helps pump out the inflammatory, mediators that are in there causing the pain. But, literally your nervous system has different sensory inputs to it. It senses hot on a different nerve network. It senses cold on a different nerve network. It senses vibration from a massage gun. It senses touch. And those are all different tactile nerves that compete for a signal back to the brain. And I just think the cold pathway back to the brain is probably one that's related to a sensory input from our autonomic nervous system that makes us bristle a little bit and makes us tense up some. So I think that's probably what you're associating with the fact that cold doesn't feel as good as heat does. It's using heat each morning bad for an achy something. Heat's okay in the morning. I mean, a lot of times you're stiff, so heating something prior to movement is not a bad idea. There are some phenomenons out there in therapy that we call it a heat and stretch. So something that's tight, like a hamstring muscle or something like that. We may put heat on the joint prior to doing stretching with it. So using heat in the morning's not bad. If you're using anything, whether it's hot or cold, I know I've talked to a lot of patients over the years that use heat, and it feels better to leave it on for long periods of time, like sitting on a heating pad for a long period. But I would only do it for 15 or 20 minutes at the most, no matter what you're using, either hot or cold. Just anecdotally, I don't think you need to use it any more than just that little bit amount of time, because the body's going to change the physiologic response if it's on there for too long.
I just want to thank you for your wonderful wealth of knowledge and sharing it with us, Gregory. Are you, you sound like a kinesiologist, like you know a lot about all the functions. What's your background? Do you mind?
Well, I'm a certified athletic trainer. That's what my first license was back in 1999. And then that was while I was in physical therapy school. So I'm a licensed physical therapist. So those are my two main credentials. But I've been a physical therapist for 21 years now. So I've seen a lot. And as I was saying, sort of how I would go about looking at the body. That's why I kind of opened up the questions early. Is in this format in Zoom, I'm looking at myself talk a little bit, so it's kind of hard to know if I'm being repetitive or not. So I'd rather just talk to people and get an idea of what they want to know about. But a lot of what our base knowledge, Deborah, is on anatomy and physiology of the body. So it's not uncommon to have a physician refer someone to us with just a generic description of low back pain or knee pain, and it's up to us to figure out why they're having pain. Granted, we get to see you for, we schedule our appointments for a whole hour, so we give a long time period. We can get a good history on what's going on, and then based on our history, we can figure out what kind of tests we want to take down that path to say, okay, we're going to rule this in or rule this out. And then, once that takes place, we usually have plenty of time left over to start doing our exercises, or again, if there's manual techniques or some other treatment option, to apply those on day one and just start getting you better from the information that we got from our little, sort of interview with you. So,
appreciate the open forum. It's very informative.
Oh, good. I'm glad you liked it.
Thanks, everybody. Lots of thankful chats, messages. Appreciate Greg's time today. It sounds like he's very busy.
Oh, well, not too busy for this. I enjoy doing this. So I thank you for having me on. It was nice to share some information and hopefully help some people out.
You have time for